Corneal hydrops is a rare condition seen in very ectatic corneal diseases like keratoconus, pellucid marginal degeneration, globus, and post-LASIK ectasia. It occurs when a break produces in the descent and/or dua layers, which causes aqueous to penetrate the stroma responsible for corneal edema, causing decrease in visual acuity, photophobia, and tearing. We believe that surgical management is mandatory to quickly heal the cornea, reduce the symptoms, and improve visual acuity. Deep corneal suturing is the most important step. The orientation of these sutures must be perpendicular to the main axis of the descemet break, which is difficult to assess behind the huge corneal edema often present. In this video, we'll show the interest of corneal OCT to assess the main axis of the break and therefore to properly orient the deep corneal sutures by following a real patient with corneal hydrops in a keratoconus eye. Our patient is a 35-year-old male with a history of advanced bilateral keratoconus and scleral lens wear, presented with 5 days of sudden worsening vision, redness, pain, and photophobia in his left eye. The ophthalmological examination reveals conjunctival hyperemia and central corneal opacity with localized corneal edema. The use of corneal OCT allows us to localize the stromal edema as well as the detachment of the descent membrane. Tomography is our main tool of choice to orient the suture. It helps us disassemble the rupture if it exists or the diastasis of the descent membrane. The treatment chosen in this case is mainly surgical. Two vertical deep corneal sutures were performed under topical anesthesia to bring the edges of the descetic and/or the Duas membrane horizontal rupture closer together. The number of sutures depends on the side of the duodescent layer's break, assessed during corneal OCT, and not by the size of the edema, which is greater. Sutures are separated by 1 mm of distance. Sedal sign is mandatory since the acquisition often reaches the subepithelial space and shouldn't be frightening for the surgeon. The ophthalmological exam after 24 hours post-compressive suture surgery shows us the localized vertical stitches. However, the tomographic section reveals a non-significant decrease in stromal edema. Preventive management of the fellow eye in a patient with hydrops is mandatory. An epi-on cross-linking treatment is performed on his right eye. The corneal soaking with riboflavin is made using a 4400 volt scleral lens as a reservoir and fitted on the eye for 1 hour. Oxygen supplementation is also mandatory during cross-linking treatment. At the 1-week follow-up, the patient described a persistence in the initial symptoms. The ophthalmological examination reveals a stable corneal opacification. We then decided to redo the corneal OCT to understand what is happening. A rupture in the descent membrane is clearly visible this time and requires a second suture with another orientation. Our patient is put under corticosteroids and benefits from a second compressive suture after removal of the first surgical thread. The technique used is identical to the one used the first time, with a change in the direction of the suture, dependent on the orientation shown in the OCT. The corneal OCT reveals an almost complete regression of the corneal edema and the continuous duodescent layers well attached to the corneal stroma. 1 week after the second suture surgery, the patient is still under dexamethasone eye drops 4 times a day and is feeling better. Corneal opacity becomes less important and is located pericentrally. Visual acuity is zero point 0.5 under his old scleral lens, but there is a pericentral touch as seen in fluid images used in slit lamps. If it persists for 1 month, the scleral lens fit should be changed for a higher vault. Sutures would be removed after 1 month with the stop of eye drops. In summary, this real case of corneal hydrops is delicate. It required surgical revision of the deep corneal sutures oriented by OCT 1 week postoperatively to be able to achieve a disappearance of the corneal edema. Deep corneal sutures performed to treat corneal hydrops should be oriented perpendicular to the major axis of the duodesmic membrane rupture for maximum effectiveness. This can only be achieved by performing non-invasive corneal imaging such as OCT, which is also important for postoperative evaluation and follow-up. In the majority of cases, corneal transplantation can be avoided.